Hello, this is Will. Welcome to Research Pod. Opium has been used as pain relief for somewhere in the region of 5,000 years. The current crisis facing global health systems has its roots in only the last 100 years, with the development, prescription, and highly habit-forming tendencies of synthetic opioids, such as heroin, codeine, and fentanyl. Nonetheless, the usefulness of opioids in treating severe pain has yet to be matched. So, what if there were a way to deliver on their pain-killing potential while reducing the likelihood of addiction? This is the work of Dr. Stefan Clemens and Kori Brewer at East Carolina University, whose separate research paths converged 10 years ago, and today could mark a turning point in pain management and drug addiction. Kori, Stefan, hello.
Hey, Will, how are you?
I'm keeping well, and thank you both for joining us today. By way of introduction, for everyone listening at home, I was wondering if we could hear a little bit about yourselves and how you've taken different paths to end up working on this project together. Kori, if we could start with you.
I have a PhD in physiology. Actually got it here at East Carolina University, where I'm currently on faculty. So I had a close friend in college who had suffered a spinal cord injury. And I think the thing most people think about when they think about spinal cord injury is the paralysis and the loss of mobility. But one of the things that he complained about most frequently was this pain from parts of the body where he, quote, couldn't feel anything, right? So if you touched his legs, he couldn't feel you touch them, but he would tell you, my legs are on fire. It feels like someone's squeezing my legs. This is what's keeping me up at night. I would rather trade my mobility permanently if I could get rid of these sensations. So when I started graduate school, I focused on neuroscience with that idea of kind of sensory systems and how sensory systems respond to injury. Did a concentration in neuroscience. And after that, I went to do postdoctoral training down at the Miami Project, which is a paralysis research center at University of Miami. Down there, I started working on the problem of neuropathic pain after spinal cord injury, and did all my training in trying to identify mechanisms by which people develop pain after spinal cord injury and potential interventions for those conditions. And so that kind of focused my pre-faculty career. And so luckily when I came back to ECU as faculty, like I said, a few years later, Stefan came on. And while I had continued working on kind of mechanisms of pain after spinal cord injury and potential ways to intervene using animal models, when Stefan came on, I had started looking at the role of opioids in managing spinal cord injury pain and the fact that they didn't work well, that there were a lot of problems even back then with them. And so when Stefan came on with his knowledge of the dopamine system, we started recognizing the overlap between the opioid system and the dopamine system and how we might be able to exploit one versus the other to get the end result that I was interested in, which was analgesia or pain relief.
Yeah, so hi, my name is Stefan Clemens, and I've had a bit of more circuitous route to get to East Carolina. I have a master's in biology from the University of Münster in Germany, a PhD from the University of Bordeaux in France, and in both cases I was working on understanding modulation of neural circuits and how it comes that a fixed wired circuit can produce multiple behaviors. I was always challenged in understanding how this behavior occurs. And when I got into my postdocs in particular, I was looking at individual entities of the nervous system that would control locomotion or locomotor aspects. So we could identify individual neurons and how they behave and change as a function of something being added to that in terms of dopaminergics or other neuromodulators, as they are called. I did then two postdocs in Atlanta, one at Georgia State University and one at Emory University School of Medicine, where I then finally came from an invertebrate background to start working on rodents and mice, spinal cord function and the role of dopamine in particular. And I was looking at how dopamine shapes and modulates spinal reflexes. From there on, with the work of advisor there, I developed a model of restless leg syndrome that was based on the dysfunction of dopamine in the spinal cord. And when I joined East Carolina University in 2008, about 10 years later than Kori did, I came then from this angle of trying to understand dopamine function in the spinal cord. And when we sat together and talked in hallway conversations, Kori and I chatted about how her animals after spinal cord injury showed similar responses to the animals I had brought up with me from Emory University. And so she had this well-established line with spinal cord injury and the chronic pain and the opioids not working. And she at some point simply asked, well, why don't you test the opioids that we use on your dopamine model? And it turned out they didn't work. And so that was kind of, wow, this is the moment where we found perhaps we have now an angle if we complement rather than destroy this dopamine pathway, if we enhance it, if we can improve pain outcomes overall and perhaps even in chronic pain conditions.
What is pain? That's probably a pretty big question. There's lots of different types of pain, different sources, but how do we, on a physical and neurochemical basis, experience pain?
So there is an official definition of pain that's put out by the International Association for the Study of Pain, which I'll probably get wrong because I don't have it written down in front of me, but it basically says it's a complex sensory and emotional event that is associated with tissue damage or potential tissue damage or anything that is described by a patient in those terms. And so when they try to put that in lay terms, what they say is pain is whatever the person experiencing says it is when they say it's happening. And I think that what that underscores is the fact that it is an extremely complex event. And because it's difficult to separate the physical biochemical part of pain from the emotional and affective part of pain makes it a really challenging problem. And so two different people having the exact same experience will describe the pain completely differently. One person may say it is painful, another person may not, because it's influenced by your history with pain, by your background, by your personality. So it is a difficult, complex problem. Now, there are some underlying biological processes that we know contribute to the perception or generation of pain in all people. And so that's where we try to target first. And then you can have to layer on kind of considering the harder to define aspects of pain, like someone's experience, someone's emotional input, and that type of thing.
I think pain is, from my background, simply too complex. And so what I'm trying to get to are those what are called nociceptive pathways that lead to pain. So you have pathways arising that say, when they arrive at the brain level, oh, this is painful, but they are already controlled at different levels of the nervous system, particularly the spinal cord in our studies, where we can look at identified neuron populations, how they talk to each other. Pain is extremely complex, as Kori pointed out, but we try to access that pain pathway prior to even becoming pain and looking at these pathways that lead to the emotional aspect of pain. And that's where our models have strength and show promise.
I like that distinction, actually. You can think of pain as how the brain interprets a particular type of sensory input. So we know the neurons involved and the circuits involved in transmitting pain. So the experience of pain is how an individual interprets the activity through those systems. So if we can control those systems that transmit the pain, we hope to intervene before those signals get to the point of being to the brain where they can be interpreted as pain. You hope that any pain treatment is directed towards the mechanism of that pain. So we know that if someone sprains their ankle, it's very painful, and that pain is generated from an inflammatory reaction that is started in the injured tissue. So drugs that target that inflammation should effectively combat pain under those conditions. I would say the broadest class of drugs are targeted inflammation. So non-steroidal anti-inflammatories Steroids themselves are great pain medications because they reduce inflammation. Several years ago, there were the COX-2 inhibitors that came out for a while, but again, they targeted a specific enzyme in that inflammatory pathway. So all these had kind of a similar mechanism of action, just targeting different parts of that inflammatory pathway. So that's probably the biggest class of pain drugs that are commonly used. Opioids are a little bit different than the NSAIDs. Typically, would only see them used with moderate to severe pain. And they're not necessarily targeted towards the underlying mechanism of the pain, but what they do is prevent the neurons that carry the pain information to the brain from being activated. So if you were to have an acute injury or surgery, opioids might be given during that recovery period to prevent the person from experiencing the pain. The problem comes in that those same drugs also activate areas of the brain associated with pleasure or reward. So you might, a side effect is that even when the injury has healed, the pain should have subsided. A patient might want to continue to take those drugs for that pleasure or that kind of euphoria that they got when they were taking them for the pain. And so clearly that's when we transition into a side effect that we don't want to see with these drugs.
So when it comes to opioids and their prescription for severe and intense and long-lasting pain, at what point does that change from being a treatment to a problem, thinking of some of the opioid problems that society is facing broadly, and then how that is leading, perhaps even challenging, treatment options for pain management, coming at things from your angle?
Well, I think the problem comes in the fact that really there have been no studies of long-term effectiveness of opioids. So there's lots of studies acutely, and they know that they're great. So I think if you're in a controlled setting, someone comes to the emergency department and they need severe pain control, they're great there. But there really has not been any controlled scientific studies of their effectiveness when used chronically. But because they were so effective acutely, they said, oh, well, we'll lay them out for people to use for chronic long-term pain. And what's developed because of that is what everyone talks about currently as the opioid crisis. They have severe side effects, which include propensity to create addiction pretty readily, the need to escalate doses over time when people become tolerant to the effects of the drug, respiratory depression, so all types of things that can put people at risk. And then, of course, accidental overdoses as people try to increase that dose to a dose that provides effective analgesia for pain. So I guess what we've learned is even opioids may not control chronic pain over time. When they're used that way, they can create a host of these unwanted side effects. Now, I want to temper that by saying I am not a clinician, right? I'm not a physician, so I'm not prescribing opioids or that type of thing. I'm talking about this in terms of the research behind them and what we know on a policy level.
And to come back to the point, well, about when do we think it might actually lose its efficacy? I think what Kori just said is the key point is as soon as there is a need to increase the dose, that might be the trigger point when alarm bells should go off, that it's no longer a chronic treatment, and this is now on the verge of becoming something that is no longer effective, so we increase the dose, and then comes all the subsequent problems that Kori just listed. So I would probably start again with the clinical trial that we have initiated. We were working on two parallel systems, Kori and I. She was working on the spinal cord pathways that are affected by spinal cord injury, and I was looking at possible spinal cord mechanisms that could explain the symptomatology in restless leg syndrome. And restless leg syndrome is commonly treated with a certain set of dopaminergics, initially at least, and the efficacy is there, it works well. And we had based this genetically modified animal model as a result out of that was missing this particular molecule to process the dopamine or the dopaminergics. Kori had been using opioids with marginal success in her injury animals. The restless leg syndrome model that we had at the time and the spinal cord injury model showed changes in their spinal cord behavior, spinal cord mediated behavior in reflexes. So what we were doing, we were testing essentially how sensitive are the animals to a painful stimulus. The spinal cord injured animals showed increased excitability, as did our restless leg syndrome animals. So they showed phenotypically a similar effect. And then it was simply really, okay, Kori, you are working with opioids. We have this dopamine model. Let's try if the opioids work actually in our model or not. That was simply the curiosity question. And it turned out that in this animal model for restless leg syndrome, they were not working. And that brought us to thought, wow, so if the dopamine pathway is compromised at the spinal cord level, again, we were looking at the system, not the pain per se, but the neural circuits, if you will, that are at the origin of the pathways that signal to the brain what's going on in the spinal cord. We found that both animal types showed a similar responsiveness or lack of responsiveness to the opioids. And so suddenly we had the injury model and we had a mechanism, a potential mechanism by which the opioids were not working properly. And so we had this dopamine knockout, as we call it, for a specific subtype of the receptors. Instead of knocking out this receptor, if we now use a drug that is targeting this particular pathway, shouldn't that improve the outcomes even in the injured animal? And that is what we found out. We used compounds that are clinically approved for different diseases like Parkinson's and even for restless legs in the spinal cord injured model in conjunction with the opioids. And suddenly animals that had not responded previously were responding to the analgesic effect.
What is blocking what there? What are the atomic details to explain why this is happening?
So morphine is supposed to be working through its morphine receptor, in particular the receptor subtype called mu-opioid receptor, and Kori knows much more about that, while the dopaminergics that we have been using work through a pathway mediated by a dopamine 3 receptor subtype. Both of these molecules sit in the membrane of the neuron, and both inhibit a similar intracellular pathway that modifies the signaling within the neuron, how molecules talk to each other, and how these molecules in turn control the excitability of that neuron. So if you have a drug like the opioid attaching to its receptor, it reduces the excitability in this postsynaptic neuron. And similar, and the same pathway for the dopaminergics. So we think there's a convergence of intracellular pathways that we simply tap into that have been overlooked so far.
A point that I think is interesting about the mechanism is one thing we've learned in our spinal cord injury model is that injury induces changes in those mu-opioid receptors on the cell membrane so that they become phosphorylated. And once they're phosphorylated, then they can no longer bind a ligand. So it's basically like taking the functional receptors away. So we create an injury, those mu receptors become phosphorylated, but they're no longer functional. But because this dopamine 3 receptor activates that same intracellular pathway, it gives us another avenue by which to stimulate the intracellular pathway that leads to all the effects Stefan described, which was decreased excitability of those cells that would normally transmit pain. And so we were able to exploit that overlap in signaling that he described to kind of bypass that dysfunctional opioid or mu-opioid receptor.
There's a certain irony to the idea that an injury will numb the receptors through phosphorylation to the painkillers you're trying to actually administer.
That is correct. That's an irony to it, but that's one of the reasons. There's several types of pains that don't respond well to opioids. Neuropathic pain or pain that occurs after nervous system injury is one of those, yeah.
In the animal model, we have now at least two models of chronic pain, one centrally induced, one peripherally induced, and they show overlapping responses to these drugs. So I think that strengthens our approach and our hypothesis.
This whole idea of it being dopaminergic mediated process is just kind of coincidental. Our recent studies, we created a set of spinal cord animals and they kind of diverge. About 1/3 of the animals are responsive to opioids after injury and about 2/3 aren't. And so we're like, what's different about these populations of animals? After a period of time, drew some blood, ran some metabolomics, right, which is just kind of a way to get a broad view of any differences between the animals. And we found that the big distinguishing difference between animals that responded to morphine versus those that don't were changes in the dopamine system, right? Dopamine metabolism, dopamine synthesis. So there's some real relationship here between these two systems that seems to be controlling the response of animals to opioids. So I don't think it's just kind of a mistake or a coincidence that this particular dopaminergic works. It seems like the pain conditions that don't respond to opioids also have alterations in this dopamine system, which we think we're restoring by adding this dopamine 3 receptor agonist.
That leads, I suppose, quite neatly to it was a renal colic trial. Is the recruitment still enrolling for that? For any clinicians who are listening to this and want to get involved, or anyone else who's clutching their kidneys and wincing in memory like I am.
Right. So we were actually very excited at the opportunity to test our kind of preclinical data that we generated in the lab in a human population. And the one thing that allowed us to do this is that we were using previously approved FDA drugs, just repurposing. So we weren't having to get approval for new investigative device or anything like that. Our goal is to create a good new chronic pain treatment. The first step is to just see if it provides analgesia in the acute setting. And so the goal was what we'd seen in our animals is that we could take a dose of morphine that on its own provided no analgesia in the animals. And if we added the D3 receptor agonist, in this case pramipexole, to that, you now got better analgesia than you would get with a high dose of opioid. So the idea was, can we make this work in humans, right? So we created this study using an acute pain condition. Since I'm in the emergency department, I work in the emergency department, not as a physician, as a researcher. I consulted with the physicians down there, and they said one of the most common acute pain things we see are kidney stones. And it's severe pain, and it's something that we use opioids for a lot. Try the nonsteroidals first. If that doesn't work, then we go straight to the opioids. So we set up this study where patients would get, it's suspected that they have renal colic or kidney stone pain. They would get a standard dose of morphine or half that dose of morphine plus a low dose of the pramipexole. So it'd get randomized to one of the two groups. We started the study actually a couple years ago. We had to shut down due to COVID because anybody non-clinical had to be removed from the space. And so we're about to get started back up. We were about 25% through our enrollment, and the early data looks encouraging. Our goal was just to show not that anything is better than morphine, but is as good as, right? So we can get the same degree of analgesia by cutting the dose of morphine in half, but adding the pramipexole as we can get with a normal dose of morphine, to show that we can reduce people's exposure to opioids. This is a good analgesic drug, right? Morphine works, but if we can minimize the dose of morphine that you need to get effective analgesia by adding on this adjuvant, then you have reduced people's initial exposure to morphine. And then if that lasts long term, maybe you are now working with doses of opioid that are not going to produce the side effects that we worry about, the tolerance, the addiction, the dependence.
Now, something that I remember from my time working as a medical reporter, drug repurposing, that's tough to fund, and the work concerning some funders that they did not know how the drugs would interact. That even, the two known side effect profiles of independent drugs, when combined, might have some kind of weird synergy that posed a risk. Is that something that you're worried about in this trial, or is it something that the animal models just completely cleared you of?
I think the animal models give us a good indication that we are likely on safe waters at this point. By reducing the opioid exposure to levels that are non-effective on their own, and they don't give any euphoria on their own, these clinical studies only looking at the effects of this combination on chronic pain. But based on the animal data that we have, we think that a reduction of the opioid by half and then adding on a low dose of pramipexole does not lead to any drug-seeking behavior side effects that we know. It does not lead to tolerance that we know of. If we ever do this study, the same drug profile, we give these animals a repeated exposure to the opioids, they develop tolerance within a week, easily. With this combination drug, we have not seen animals develop this tolerance. We have not seen that these animals show any signs of what is called drug preference. So when they are tested in a T maze where they can go either left or right, they had exposed in one but not the other, and we test them again after the end of this trial, there is no indication that these animals show any drive to go to the chamber that they received the drug in. So we don't know what happened in humans, of course, but we are following the very strict IRB guidelines here on this one to make sure that we stay at safe levels. And we are actually right now in the process of developing a chronic study with the Veterans Administration. We're trying to get this study into a chronic population with an MD in North Carolina. And at that point, yes, we will be able to assess much better in detail if there are any additional side effects that we need to worry about. But it will be tempered as much as possible.
This could have potentially societal level implications of people not being at so much of a risk of opioid dependency, not just a much cheaper, effectively a half-price way of treating pain and alleviate a lot of funds within a healthcare system. Assuming this is as effective as full-dose morphine, what would be the potential implications for it, looking maybe as a new standard of care?
I think the question always comes up about why even look at opioids? They're bad. We know how dangerous they are. Should you even be considering something that still includes them? So I look at our CDC put out an updated guideline for opioid prescribing in 2016. And basically, their conclusions were that opioids obviously have risks, but these effects are dose dependent, which say, okay, lower the dosage, you lower the risk. It doesn't say that clinicians should not use opioids. It says when they do use opioids, they should prescribe the lowest effective dose. So we think this is ticking that box. I mean, if we are totally rose-colored about it and look into the future, what we hope is that this provides a total alternative or better option for clinicians who are faced with someone who's really suffering severe, either acute severe pain or chronic long-term pain that's not responding to anything else. This will give them something to use that can be effective without creating the side effects that come with opioids used at current doses that they're used. I think the idea that we've kind of spent a few years in the lab testing things on animals that has the potential to translate like that, I think that's a dream for any basic scientist. And it's fun to think about. And I think, again, all else staying equal, that's where I think it has the potential to go. And I think there's some people interested in developing an idea that Stefan can talk about.
Yeah, so when we first presented these data, I was contacted by one of the attending physicians at the time, and who said that she had a patient who was not responsive to either of these two drugs on their own, the dopaminergics or the opioids, for the treatment of, yes, it was actually a combination of pain and restless leg syndrome. And she told me 2 years later that she had used this combination that we had introduced at the time. Again, these data have not yet been published, She used the study in a chronic setting, so she gave this patient low doses of each. Last time I spoke with her, it was 2-3 years after she had started the treatment, and the efficacy was still there. That gives us hope that data we get from the animals can fairly readily translate to the human.
Well, if there is anyone listening to this who finds themselves in a similar prescribing circumstance, or anyone who's maybe working locally and would like to get their clinic involved, what would be the best way for them to get in touch or find any more of your research if they did want to just even keep track of things so they know where things are at and how they can maybe start participating?
So currently, this is just a trial in our hospital. Currently open to expanding it to other centers. I think that's what eventually we're going to need, different experiences, different pain populations. Like Stefan said, our goal next is to look at veteran population with chronic pain.
For this chronic study that we are envisioning right now, one of the goals is that we may be able to identify, based on blood samples, patients who may respond, who will respond to these opioids, and those who will not, prior to even giving them the opioids.
Ideally, because really what we've talked about so far is using this combination to treat pain. We have no claims to whether someone who's already addicted to opioids or dependent on them, if you can switch them to this. We don't know how it feeds into the addiction side of things. We know that this combination doesn't create the same kind of addictive profile as the higher dose opioids do on their own. But again, we're not addiction specialists and we haven't really rigorously assessed whether this combination might be used to treat addiction or as an opioid replacement therapy for people who have been on opioids a long time and need to decrease that. It's a whole new avenue that has yet to be examined, but we hope all those things will come out of this first step.
We are hoping that this, once it's an approved and patented idea, that we will find collaborators, companies possibly willing to license this idea and then get it out to the appropriate populations as quickly as possible and safely as possible.